Dr. Avinash, sir? Dr. Avinash, shall we start?
Yes. Yes, we can start. No problem.
Sure, sir. Thank you, sir. Welcome and good evening to everybody here. Thank you so much for joining us today. The IAPT is back after a lull in the events. That was because of a lot of issues that had happened, and we were not really able to gather people together for this. And at that time, it was more important that care for COVID had to be taken care of more than the academic at the psychiatry level. And so that's how it's been for the last few months. We've all had struggles which we've overcome, and we've come back this time. This time we've started a series called the Launching into Private Psychiatry. This is going to be over multiple chapters, and this is looking at trying to address one of the greatest contributions to the healthcare sector in India. That's from the private psychiatry, private sector. And private psychiatry itself is a big contributor to providing mental health care across the country. So for that event, we've had very graciously Doctors Anukant Maithal and Dr. Avinash D'Souza, who are office bearers of the Indian Association of Private Psychiatry, joining us and collaborating here. So in this panel, you'll see a very unique mix of things. You have two very eminent established private practitioners in psychiatry who are also office bearers, who have seen the need and are contributing towards developing private psychiatry with decades of experience here on the platform, informing on how informing on certain aspects of private psychiatry. Alongside, you will see people, two people who are there, who are young and dynamic private practitioners who have begun their private practice during the COVID-19 period. And we'll get to hear from them as well about their experiences. And we also would like to acknowledge here the presence of our senior patron, Dr. Santosh Chaturvedi. He is a retired senior professor from NIMHANS, who is now in the UK. He's also graciously joined us from there. And also been encouraging us constantly towards building up the IAPT and its events. So without further ado, I'll just give you some basic housekeeping rules here that we're going to follow. We request that if you are continuing in the meeting, we'd like you to remain muted throughout the meeting until unless you're called upon by the host. You can indicate that you want to ask your question verbally by raising your hand. We also encourage that you can put questions in the chat. We will take up the Q&A after the segments by each of the presenters or the panelists is over. Aside from that, we'd really love for you to participate and share your views, share your feedback. At this point of time, the IAPT it also requires your membership and subscription. We'd like to know from you what else we can do to help you out and what the niche areas that you think are necessary that need to be addressed. We'd love to know all of that from you. So do write us, you have our contact, and throughout this, if there are things that you're not able to get clarity on, we'd love to help you out. We'd be there to do that as well. I'm going to hand over right now to our senior patron, Dr. Santosh Chaturvedi, for a few words, and then we will move on to beginning our panel.
Yeah, thank you, Sharad, and welcome to all of you. And it's very nice to see that IAPT has started its activities again, and starting with a very important step of understanding private psychiatry and private practice in psychiatry. I know most people in most institutions keep complaining that once they finish their MD, they don't know about so much about their career choices. All they know about is how to become a senior resident or a faculty. But suppose they have to jump into the mainstream general population, how to do and what to do. So I think, as I will just echo your words, Sharad, you have two very eminent people. Avinash D'Souza is, he's grown up in a family of private psychiatrists, and of course, Anukant Maithal, and no better persons than them to give us information about that. And of course, two very, youngsters of my own colleagues, Lakshmi and Shushma. I hope they don't keep complaining about NIMHANS that we didn't train them about private practice, but rather share their experience about how they are keeping their feet on ground. And it is going to be a learning experience for me. All the best. Thank you.
Thank you. Thank you so much, sir. It's a lively listen to your words right now, and it's always been an encouragement. I will set off the panel here by giving you a small introduction about the speakers. Dr. Avinash D'Souza and Dr. Anurag Mittal are both office bearers from the Indian Association of Private Psychiatry. Dr. Anukant Mittal will be joining us a little later in the course of the event. Dr. Avinash will begin, and he is the Honorable Secretary General of the Indian Association of Private Psychiatry. He's also a prolific writer, and he's also a very eminent private psychiatrist in Bombay. There are lots of positions and titles he holds. I wouldn't, want to take his time by even enumerating all those positions and all those details here. I just hand it over to you, Dr. Avinash. Your topic is about continuing academician and researcher journeys while in private psychiatry, something that you've been so ably doing all these years, sir. Over to you, sir.
Okay. Good evening, everyone. And what I'm going to do is I have purposely not made a presentation because I don't want this to be a very formal lecture per se. But I'm going to share with you my experiences over the next 15 minutes about, my journey as an academician and a researcher while being, I would say, 80% into private practice. So being mostly a private practitioner. Now, I'll tell you, I did have one added advantage, as what Dr. Chaturvedi sir mentioned, that I had both parents who were into private practice and both parents who were in the era of honorary consultants. So they were honorary professors and heads of two separate departments in Bombay. So, I luckily had the right blend, I think, of both worlds, when I started my career. So of course, they were already retired professors by the time I joined my residency, but I had the best of both worlds when it came to academics and private practice. But that is one added advantage. But apart from that, I think I've always said that clinicians and people in private practice uh, somehow will do very well on any research team. And the reason I say that is because they always have that added clinical edge to give impetus to their research findings. So I always feel that the chances of them giving impetus to their research findings is there because they have that added clinical knowledge of what are the research questions we need to address. That's the first thing. So one of the things which I will tell everyone is that however busy you get in practice, you're bound to get busy month by month, year by year as you enter into practice. But I think in the first 4 or 5 years, what's very important is that you learn to take up whatever teaching assignments you get. Generally, you get some teaching assignments. These may not necessarily be postgraduate. They could sometimes be, you're teaching a group of psychology students. It could be you're teaching a group of social work students. It could be, a college that wants you to be just there for a few sessions. It could also happen that you're teaching some undergraduate students. There are a number of private medical colleges in your area of practice that are looking for visiting consultants to their college. So you would thereby have some association with a medical college set up. There are some government medical colleges also that have a visiting or an honorary consultant kind of post which is available. So do look for that. The pay is very meager. You probably, I'm working at Sion Hospital, which is Lokmanya Tilak Municipal Medical College for the past 12 years. As a visiting consultant, I get paid 3,000 rupees a month. So, but it's not that, it's the joy of, being part of a team that builds postgraduates, and the fact that you can give your added private psychiatry advantage to them, which becomes very important, wherein when you see a case, you always discuss with them that okay, this is what we're doing in this setup, and this is what we're probably going to do if the case came to us privately, and these are the precautions you will take. And I think that's a tremendous boost for the department, and I think even for the residents, because they love to have that knowledge of what would actually happen in the real world. Now another thing there is, so look for these appointments. The first thing is look for any teaching appointment you can get. Why? Because once you have a teaching appointment, I believe you're forced to read. You don't have a choice. Whereas once you sort of enter private practice, you get so overwhelmed with the work all around you and the amount of networking you have to do and to garner your practice, that you somehow lose that trend of reading. So whereas when you're attached to a teaching unit, psychology, psychiatry, social work, whatever, you have to read the basics again, because you would be invited to take some lectures and something, and take a lot of community lectures. It's very, very important. Now, you may say, how has that got to do with my academics? Because when you take community lectures, you read on a variety of topics. You don't read only psychiatry, you read a little bit of psychosocial, you read a little bit of environmental factors, multiple things. So I mean, as a clinician, I may be called upon to take a lecture on how to find happiness in life after 50, for a community group. So you end up reading about that topic. Your presentation is ready. Spend a lot of time on your presentation once, so that, even if you spend 5 or 6 hours or 8 hours on making a presentation, make it so well that you just have to probably add a few points. But that one topic of yours is ready very well whenever you need to use it, in the future. So you have your presentations well made. That's very important. You will be called upon to take a lecture on smartphone addiction, something that you may not really learn in too much detail, in a postgraduate course. You may be called upon to, take a lecture on how to prepare for retirement, something which, you will probably not learn in a postgraduate course. So these are topics which will make you read a little beyond psychiatry, and you will, have to delve, and you'll prepare, and it'll open your eyes, to a number of things. Like, for example, you'll also probably be called upon to say take a psychoeducation lecture. Like in the current dementia awareness week, I'm doing a lot of talks on dementia awareness, but then there are different facets. There are people who want us to take a lecture on non-pharmacological management. The pharmacological management is very easy for us, we already know, but it's the non-pharmacological management from a psychiatrist perspective to tell them that gets very difficult. So then when you prepare well and you have everything in order, it becomes a lot easy. So keep in touch with academics. That's very important. That's the first point I will say. The second thing is, write to various institutions and offer to take lectures whenever they need you. So it could be that there is a medical college that probably calls you once in 3 months for one lecture, but at least you then have to read once in 3 months, and you probably go there. So it's a good thing for you to be part of that academic activity. Sometimes it can happen that you may be called. I mean, I will tell you this. I teach at the SNDT University in Mumbai, which trains MA psychology students. And when I joined SNDT, they asked me whether I would be able to take the entire psychopathology paper, which probably covered a lot of psychopathology that we've studied in post graduation. And I think what used to happen very beautifully without me doing anything was that every year, since I would have to take everything right from mental status examination to anxiety to OCD to schizophrenia, I would end up revising my entire psychopathology, once a year, because I would probably read a little before my lecture, update my slides, and have everything in touch. So I practically read through the entire MD psychopathology syllabus once every year, because I had a series of lectures that I would take yearly for them. So this is one major advantage which I think you will get if you are attached to an academic institution. The second thing that comes is research. One of the biggest challenges that many private practitioners face when it comes to research is, how am I going to do research which is ethically viable, ethically correct, and such that I don't sort of violate any ethics. And that's something which is very important. So again, being attached to an academic institution gives you that added advantage that you can be a part of research projects that they undertake. So that's one thing which you can do. One of the other ways is that if you could be a part of certain multi-center studies that happen, where you might contribute a small number of cases, but even if you contribute a small number of cases, they manage the ethical clearance. You may not really probably be able to get an ethical clearance from your clinic per se, but there are independent ethics committees that could help you in that. And these are clinical studies. They are not interventional studies where you know going to cause any harm to a patient. These are database studies where they're primarily phenomenologically based or symptom based, wherein they need a huge data set, but they need a varied data set from different people. So you might end up contributing 30 or 40 or 50 patients, not more than that, over a period of 6 months. And it's something wherein you would be a co-author in that study. Because if you're not a postgraduate teacher, I think author number, number author you are, whether first, second, third, fourth, fifth, doesn't really matter. I mean, as long as you're part of a huge research team, that's what matters more. Another thing is when you're part of the academic institution, there is a lot of research that happens there. You have an entire ethics committee at your disposal, which is of the institution. You can get your projects passed there and engage residents. See, one of the things that I have been after all my residents at Sion Hospital is you have to do research. Any interesting case you see, we have to publish as a case report. No case should go unnoticed. So the thing is, every case has to be written up that we see. So we started with case reports, we started with case series, then we went on to data collection. Even we told students that the thesis topics you choose have to be clinically viable and not just to, finish a thesis. And then in such cases, and thereby we started building our database. We started you collaborate with organizations like say SCARF, or you collaborate with organizations that are, private but at the same time into research. Organizations like Sangat in Goa that does a lot of research, and they do clinically based research. So we're doing a study with SCARF which is on first episode psychosis phenomenology. That is something you can do very safely without any ethical violations. Similarly, there are the epidemiologically based studies or symptom based studies which Sangat does, which again are not interventional studies, where you don't have to worry about ethical violations happening in a very big way. Informed consent, yes, we definitely take, but they're not going to be interventional studies. Another important aspect I'll tell you, which is neglected, is everyone collects data. Everyone is able to collect data. Everyone is able to make an Excel sheet, but the problem that happens is writing the paper, which very often becomes an issue. um, I don't know how people could manage that, but I can, take this moment of glory to boast that, I spend on an average at least uh, the morning time 2 hours, for my academic and research work. You may not be able to do it every day, but you'll probably at least be able to do it 5 days a week. So, but for that you'll have to get up at 6:30 and spend time from 6:30 to 8:30 very diligently reading stuff and, looking up your research work, helping in research papers, and learn scientific writing. There is no good course. I mean, of course, you all are from NIMHANS and you all are taught a lot. I mean, my course speakers and others, but there are no courses that teach you good scientific writing. I always say that the only way to learn scientific writing is to read scientific papers. So, make sure that you read at least 1 or 2 papers a week. So when you read 1 or 2 papers a week, underline new words that you come across. Increase what I call your scientific writing vocabulary. That is something which is very important. One of the exercises I give my residents is that I want you to tell me this research finding in 10 different ways scientifically. So, so you learn to become versatile in your scientific writing. That's something which is important. Also, you have to improve your English a bit, because not everyone is comfortable with English as a language. So even, your English vocabulary, your basic English sense, you will have to improve. uh, those are things which will help you from a scientific writing perspective. Write, submit, be prepared to get rejected. It's absolutely fine. I mean, you will get rejected from many journals. It's okay. You will learn. Even if I get rejected, I always write back to the editor and say I want to have detailed reviewer comments so that I come to know, what's wrong with my paper. So you learn every time. I mean, I know students of mine get upset that we've got rejected thrice, and I tell them the maximum rejection I have faced is 17 for one paper, and on the 18th journal has accepted it. Because I think there was nothing left to rectify after 17 people found, faults in it. So you will learn. I mean, there are ways and means, and you will learn. And slowly you have to build a team. Always remember, you can't do research alone. You need to have a group of people doing research. and you need to see what your group is good in. So when I work from a private practice setup, I always say my forte is writing the paper, my forte is probably thinking of the concept. uh, we have someone who's very good in writing a project, so he writes the project and submits it to the ethics committee. He's very good in that. We have someone else who's very good in the statistical aspect, so he manages that and he'll tell us we'll use this or we'll use that, because I don't mind admitting it that my statistical knowledge is not at par, with many seasoned researchers. So I mean, I always say we need someone who's trained and knows to guide us as to what statistics is to be done. We have residents and others who collect data, which is very important, and they generally get first or second authorship because they need it for their credentials as well. And we need someone to proofread your paper. So we have senior professors like Dr. Nilesha and Dr. Sushma Sonawane in our department who only proofread our papers, and they'll tell us, this is not this sentence doesn't sound proper and this sentence doesn't sound good. Or I have a few friends who are editors of journals, and I tell them, I want you to just proofread this and tell me what you feel about it. And they'll come back to me and say, so you get a little bit of corrections done before you submit, so that then enhances your chances of acceptance, because you have senior people telling you what's wrong. That's very important. Even at this stage, I still send the paper to someone senior, to just get an idea about what I missed on. It's something which is important. Also, another very important thing is never think that you're the best in academics. No, you should always be prepared to learn, and you should be prepared to learn about new topics. Be a little circumscribed when it comes to your area of work. Don't think you can talk on anything. So there are some areas that interest me and I'm very good in them. There are some areas which don't interest me and I refuse talks if I get on them, because I tell them that's not my area of work. It's not that I'm just going to read a textbook and probably make my slides. If I can't bring my clinical knowledge to the talk, I don't take it up. So it's something which is very important. So I always say schizophrenia is an area of my interest. Geriatric mental health is an area of my interest. Child psychiatry. These are three main areas that interest me. So I work in these areas. But if you tell me we want you to talk about anorexia, I'll say no, that's not my area of work. I won't, probably talk about it. Or if you tell me forensic psychiatry, it's not my area of work, so I wouldn't probably talk about it. So you have to be very specific, and your research also has to be more in that direction. So you do more research work, so that, like most researchers, even when you present, you can quote some of your own papers. So it will add more value to what you're presenting. So those are things which I think go a long way. But the most important thing is start slow, go slow, build a team. It takes, today if I'm good, it's taken an effort of 2 decades to build a team. It's not that we've just come on top overnight. No, it doesn't happen that way. And I'll tell you this, I don't mind, again, since you're a new group, admitting it, that there are times when, if I have to travel for a conference, that's the only time I get free from my private practice. The conference is on Saturday afternoon. I reach there on Friday afternoon, so that I get a day extra to do research work. Sometimes. So I sit alone in the hotel room, don't go out, and sometimes I avoid conference dinners so that I can sit and write a paper in those 3 or 4 hours. So, I mean, there's some sacrifices you will have to make, if you want to get extra time to, probably do your work. You'll have to avoid seeing TV unnecessarily, so that you get little, time, so that you can probably, I won't say don't see TV, but avoid seeing, just sitting in front of the TV doing nothing. You will have to find time such that you'll, of course, we all have a family, we have children, we have a lot of things, we have other priorities, we have to give time. We're not psychiatrists and researchers 24 hours, so we'll have to be a brother, a mother, a husband, everything. So we have to give time for everything, so you need to balance all that out. But if you can get extra time whenever, make the most of it. That's something which I would probably say. uh, and yeah, I think that's about it. And over to you, Sharad. Yeah.
Thank you so much, sir. Thank you so much. There was lots of wisdom and nuggets for us to ponder on, and as well as things that we can definitely think on. There was this thing that we have to, I think, accept whatever opportunities come and whatever invitations come. Thank you so much for clarifying that from your seasoned position. Our next panelist is Dr. Anukant Mehtil. He is the president of the Indian Association of Private Psychiatry and also the professor and head at Rajiv Gandhi Medical College in Thane. He is going to tell us about how the training in psychiatry really doesn't gear us or equip us for private psychiatry. I wouldn't take more time in this. Thank you so much, sir, for being a part of this event, and thank you so much for being here. Over to you, sir.
Well, good evening, everybody. I hope you can hear me. Am I
Yes,
audible
sir.
to all?
Yes, sir, you are, sir.
Right. Okay. Well, I was asked to speak on a topic which is very close to my heart. Is psychiatric training so very different from what we need in private practice? Absolutely. Psychiatric training is to teach you psychiatry, is to teach you theory and clinical part of psychiatry. When you practice psychiatry, you use a lot of what you have learned. But there is something called the art of practice, which is never taught in any institution, which is not part of any training. Which is why when we conceived of Private Psychiatric Association of Private Psychiatry 21 years ago, we started a program called the Art of Psychiatry, which actually started working on teaching you the nuances of practice. For instance, no student exiting from any of the medical colleges except mine, I'm proud to say, because I have the dubious, distinct qualification that I'm a full-time professor on contract who's allowed to private practice also. So I have the distinction of being able to do both. No institution prepares you of what to do when you start your practice. Whom do you meet? How do you select your rooms? Which area do you look for? What do you practice as? What skill set do you need? What color letterhead you prepare? What does your visiting card say? How much rent can you afford? How much fees can you charge? I am going to take you through some of these things of what psychiatric training needs to teach is very different. Private psychiatric practice does not require much. It requires a largish room, probably 200 square feet, with a table and maybe 4 or 5 chairs and one examination table, a little amount of space to move around, and a very decent exit door. Not only an entry, but an exit door. You need to start thinking first of how much you're going to charge, which area you're going to practice. Once you plan on which area, whether you're going to buy a clinic or you're going to start sitting in a polyclinic, or are you going to sit in multiple so-called virgin areas where there are few psychiatrists. How are you going to publicize yourself? No college or psychiatric institute teaches you how to make yourself popular or known in the community. They don't teach you to start doing school mental health programs, do community programs, maybe with political patronage, maybe without political patronage. You do programs, you do health camps. You become known to the people. You join the Indian Medical Association. You join the GP Association, the Medical Practitioners Association. You give lectures to them. You make your presence known. You let people know that you are there. They are not going to look at you. You're not a giraffe that they're going to look and say, oh, there is a giraffe amongst us. You're not going to stand out. You need to stand out. You need to start working with people who are going to refer patients to you. School teachers, college teachers, community leaders, prominent people in the area, physicians, your colleagues, your peers, your juniors, general practitioners. You need to meet them socially, professionally, walk into their clinics. You don't need to say much. You need to give your card, introduce yourself, spend 5 minutes with them. Just tell them where you trained, what are your skills, what do you want, how do you work. Be prepared with an answer when they ask you, how much do you charge? Be prepared to listen to them asking you for a cut. Don't answer. Walk out. Or say, I don't give cuts, like I did. Walk out. It doesn't matter if there are 10 psychiatrists in 1 kilometer radius. I started my practice in South Bombay. There were 14 psychiatrists in a 500-meter radius of my clinic where I started. And I started by charging 20% more than all of them were charging. Right? You need to decide what kind of practice you want. And how soon you want to buy your first car with your own money. It took me more than 3 years to break even. That is, to earn enough money that would meet my household expenses. But I kept using a motorcycle for 20 years of my life. The reason being that I decided that I wanted to do justice. I would spend half an hour to 45 minutes with each patient. So I would maximum be able to see 8 to 10 patients a day. My students, I have 500 students that I have examined. 500 students. DPM, MD, DNB, CPS, all of them, many of them. See 50, 60, 80 patients a day. And they all tell me, sir, why don't you see more patients? And I said, I can't see a patient in 10 minutes. Because if you're practicing for 10 hours, you get 600 minutes. 1 hour away for food and drink and bio break. If you're seeing 50 patients, you're spending 10 minutes with each patient. Right? So you need to decide what kind of therapy you want, what kind of patient practice you want. I wanted to start practice with a lot of therapy. In my time, there was no therapy training available. I went to UK. I learned family therapy. I spent a year learning family therapy. I spent a year and a half learning hypnotherapy while doing my psychiatric training. I used up all my free time. As Avinash said, you need to find time. I used to spend my weekends going for courses. I learned child psychiatry. I worked in child psychiatry unit. I worked in consultation liaison units. And I came back because I wanted to settle back in India. And all this in the larger term, when I started practice, helped me start with a comfortable confidence. This was not taught to me in the medical college. Yes, they taught me what drugs to prescribe. They taught me you need to do cognitive behavior therapy. But they didn't tell me that if I'm going to spend 45 minutes doing CBT with a patient, how much should I charge? And if I do CBT with each patient, if I see only 8 patients and I charge 300 rupees a day, how much am I going to earn in a day? How much am I going to earn in a month? What is it going to pay for? It doesn't prepare you for the reality of practice. How many of you are ready to sit for 3 years or 2 years before you break even? How many days will you sit with no patient in your clinic? Are you prepared for that? Do you think? Does any medical college prepare you for that practice? No. How many of you are ready to choose the area you're going to practice, the clinic you're going to practice? How many colleges tell you to go out and work there, in the community there, to meet the doctors before you start your practice, so that everybody in that area knows. Coming soon, Dr. Anukan Mittal's psychiatric clinic with special facilities for family therapy, with special child psychiatry, child guidance unit, with de-addiction therapy. That is how you build up. And building up forms a major part of your practice. You meet. You may not start with an inpatient unit unless you have millionaires as parents or in-laws who can finance you. But no bank will give you money to start a psychiatric clinic. You have to plan, where are you going to admit your inpatients? I still don't have an inpatient unit. And almost all my patients, all my students use my technique. They make friends with intensivists. They make friends with other psychiatrists who have hospitals. And they admit their inpatients there. If they are delirium patients, withdrawal patients, or otherwise requiring intensive care, they admit them with the intensive care. Otherwise, they admit them in a psychiatric unit. They collect their consultation charges. Give them peace of mind, because they don't have to run around looking for the mama or maushi, the ayah or the maid when she doesn't turn up. It helps you prepare yourself in the initial stages of your practice to lower the burden on yourselves. And I'm not being sexist or a misogynist by saying that, especially for females who are going to be in your early years of practice, be burdened with a lot more than us lucky males are. You'll have families to look after. You'll have homes to look after. You'll have babies to look after. And in addition to that, if you have indoor patient at 2 o'clock who's getting agitated and violent in the ward, how are you going to run for it? So you need to prepare. You need to strategize. I have loads of my students go to NIMHANS, go to other hospitals after they pass out to work for some time, and then they come back and they spend time with me. They do their research. They come back 3-4 times to me and they discuss how I should practice. Should I practice in these 3 cities? Which time of the day, which day should I go to this city? Which time of the day, which day should I go to this city? Which should be my headquarters? Where should I settle down? That kind of things. You need to decide that. No college prepares you for this. No college prepares you for what drugs, what medications to write. All of you, all of us are at medical colleges where we learn, most of us in government colleges, we write Trinicam, we need to write Trankadol, we write Pacitane, we write the same old medication that have been going on for years and years. We talk in conferences, we talk in meetings, we talk in webinars of the latest techniques. But have we any experience with the newer drugs? Do we know how much they cost? Honestly, everybody sitting in here, tell me what is the cost of a strip of divalproex sodium 500 milligram of Intas, of Sun Pharma, and what? Eris Pharma. Tell me what is the cost and what's the difference? And for which patient would you write what? Do you know the cost of Pacitane, 1 strip, and the cost of Bexol from Intas or Hexilent from Talent Pharmaceutical? You know the difference in costs? So if you have a poor patient whom you're going to charge $500, how much, which medicine are you going to write? If he's a very poor person. If he's rich, which medicine would you write? It makes a difference. Whatever you may call it. Is it unethical? No. These are all drugs which are FDA approved, They are standard, right? But I have to be choosy, right? I remember many years ago, Lundbeck launched a drug called Cipralex. The same medication being manufactured in India by the subsidiaries, third parties, which were supplying Lundbeck, was marketed by companies in India at 1/10 the cost. But there were a large number of psychiatrists prescribing Cipralex. And I couldn't understand that. Right? You will lose patients because when the patient goes to the chemist, there are chemists because they get discounts. He will tell him, why does this doctor write this medicine for you? Arey, these 4 brands are the same and they cost 1/10 the cost. He must be getting a commission. You've lost the patient. You need to contact a good radiologist, a good scan center, a good investigationist, not to get cuts, but to get guarantees that you would get reliable results. And you would get quick service so that you could call them up. If there was a patient you felt had a subdural bleed, you call up the scan center and they will immediately take your patient, call you back and tell you he's got a intracranial bleed or a subdural bleed, and you could admit the patient immediately under a neurosurgeon. You need to have that. You need to be resourceful. No college teaches you that. All colleges teach you, as a resident, you write CT scan brain and you walk off. The JR tells the intern, take the patient for a CT scan. 2 days later, the report comes. By the time what happens to the patient, no one cares. Or if you have a boss like me, next morning you're whipped and you get the report, right? But you have to practice. The patient wants you to take charge and you need to be there. You have to remember that a medical college does not prepare you to do hands-on taking charge work. You get work done from your juniors. In practice, buck stops with you. You do the preparation. You do everything from the finances to the reception to setting the appointment. You know, I am a kidney transplant patient. I'm on immunosuppressants. I have not walked out of my house for 14 months. And then I walked out only because my postgraduates are appearing for exams. And in 2 months' time, I have to prepare them for their diploma exams. So I'm desperately teaching them day and night. I have a bubble prepared from my home to my hospital and back. So I go to teach them, right? But how did I come to my kidney transplant thing? Yes, I've been seeing patients online. I have no receptionist. I don't have any fancy thing. I have a WhatsApp number. I send my patients. They send me a message in the morning. I look up my diary. I book appointments. I answer to them. They send their latest prescriptions, which I already have, because the moment I access their number, I today only sat with my patients. We had the luck that I had a patient whose 1.5 years papers, every 15 days follow-up was there. And we saw the chronology of a bipolar disorder patient, right? And we had 30 visits logged in. And we went through the 30 visits and showed how a patient from mania became euthymic and then went into depression and is back again in euthymia now, right? So I asked them to send me the prescription. I see them. I send them a prescription by scanning it, by WhatsApping it. They pay me by Google Pay. Simple. I have no secretary. I have no other needs of any ancillary staff. And I'm making a decent amount. Are you prepared? Are you prepared to use social media? Somebody later is going to talk about social media. And that is very good, right? Dr. Lakshmi is going to talk about decision making, right? Purposive meandering. And you need to start talking amongst yourself. You need to start planning how you're going to practice, where you're going to practice, what kind of practice do you, and how do you make your skill set more empowered to be able to practice. Do I have any time left, Dr. Philip? Mr. Philip?
Sir, we have two more panelists. Maybe we could continue based on questions which are there. We could continue this in the Q&A, sir.
Right. So I'll just end with one thing.
Sure, sir.
It's like getting married. You choose your partner. You choose a house. Decide what loan you want on it, what furniture. Buy it piece by piece. What family you want, when you want your family, how you want to grow, how you want to save, how do you want to plan your relationships. Starting a practice is a lifelong commitment. You're married to this profession. Manage it like that. No college, no person will prepare you for it. People like me can help you, can guide you based on our experience. Don't listen to somebody who's a 24-hour armchair teacher, because he gets his money sitting. He doesn't have to run after patients. He doesn't have to worry if he's seen one patient or 50 patients. He still gets his salary. He doesn't worry about practicing on Diwali or Holi. But I tell you, I practice on Diwali because when I do my puja, Lakshmi always comes. And I've learned that from the first day of my practice. I finished my puja and there were 6 patients waiting in the consulting room for me. Right? So that is the reality of practice. You need to decide how you want to do it. Thank you.
Thank you so much, sir. Thank you so much for that very necessary reality contact that we got from you. Thank you so much for sharing so many points from your own experience and so many things that you have practiced and followed and adhered to over your practice years. We will now go over to the next panelist. Dr. Lakshmi is a consultant psychiatrist in Bangalore. She practices there. She's also finished her DPM and her MD from NIMHANS, as well as a postdoctoral fellowship in perinatal psychiatry and women's mental health. Over to you, Dr. Lakshmi. She will be speaking about making the decision, what Dr. Anukant Mittal alluded to in his presentation, purposive meandering.
Thanks, Sharad. I'm feeling that I should have been on the listening side after hearing to Anukant sir and Avinash D'Souza. But anyway, I think with 1 year of practice, I'm going to share my experience because I have had a lot of apprehensions in starting, thinking, will it be viable? Even though I was in NIMHANS for just the DPM and MD and SRship was 7 years. So 7 years in NIMHANS. I think somehow people who are in NIMHANS for a long time, or any institution for that matter, we all have apprehensions on moving out of the institution. So I had those too, and I have spoken to people then and had a lot of thoughts in my head as to how I have to do this. But the end of 1 year, I'm happy to tell you that I'm quite satisfied, more than happy than what I initially thought when I started practice. I'm just going to share the PPT only to see that I don't miss something, though largely it is my experience that I'm going to talk about. And I think Dr. Anukant sir has covered many points that I wanted to actually tell. So that way it makes my job much easier. Is it visible, Sharad?
Yes, Lakshmi.
Yeah, thank you. So yeah, I think whatever I was thinking is about why should I go into private practice? When should I go? What is the ideal time to do this? And how should I do it? I think those are the questions which everybody will have. What are the pros and cons as compared to being in an academic institution, and is it sustainable? I think the most important thing is that you don't have to keep thinking that nobody's giving you a job when you have a degree and you can actually practice. So this Dr. Avinash has spoken in detail as to, so I was very much interested in teaching. Research, I wouldn't say I was very greatly interested, but then I used to be very interested in teaching, which I enjoyed doing as a senior resident. And I would feel that I'm going to lose all of it when I start private practice. So that was one of my biggest things when I started, that I'm going to lose out on all academic stuff. And like sir was saying, we don't have so much time to read up, so we might not learn the newer things. And so that was my biggest dilemma. And I think on this, Dr. Avinash has spoken a lot on how we can balance both and how we can involve in teaching as well as research, even though we are doing private practice. So I won't go much on that. How many years of experience is required before you launch out? There's no clear answer to this. There are people like, Sushma, I think she started right soon after she finished her MD, whereas I have taken, I did 3 years of senior residency in NIMHANS before I wanted to do this. So there's no clear thing, but however, I would say from whatever I have seen patients for a year now, I would feel that at least 1 year of senior residency would be good before you launch out, because till the JRship, you're just listening to SRs or your consultants asking what does drug to prescribe, when to stop, etc. So you just maybe following orders, or even though you have your own decisions to make, you're not allowed to do so. So maybe at least 1 year of SRship would be good. That gives you the confidence to exert your decisions, or choose a drug or whatever. That confidence should be there. Otherwise, I feel you might not be very, very confident when you want to see difficult patients, etc., in private practice. The other thing I used to feel, because after my DPM, for a very short period, I used to work as a consultant psychiatrist in a endocrinology setup. And there I used to see only anxiety, depression, nothing else. And I got super bored at the end of 4-5 months, and I quit that job. So this was another thought again for me now when I wanted to start private practice, as to will I get to see the kind of cases that I see, and can I handle them? So I mean, I can tell you that there are quite a lot of variety of cases that we do see in private practice, and in this year I'm quite satisfied about them, except for, of course, very violent patients or extremely agitated, or suicidal and all that, you might not get. But other than that, there are a wide variety of cases which you will get. This I'm talking if you have a clinic, but of course, if you are working in a multi-speciality hospital kind of setup, then it doesn't matter. Even there you will get acute cases. Can we handle them? The sense of responsibility is definitely higher here. You can't admit a patient and then you say that psychologist will come and talk to you, social worker will come and handle the family. I will only decide on what drugs I need to give and go. We cannot do that. There are so many questions. The family is wanting to hear from you. They want to see improvement. They will come and check with you. So you are very, very responsible. That way, I feel the amount of responsibility as a private practitioner is really high, as opposed to being in an institution and working in a team. What about therapy? I was very interested in therapy right through my residency, and I wanted to do therapy. It again depends on how interested you are, how equipped you are, what has been your training. Of course, you can anytime upskill these things. Like sir was saying, you can always take up courses, you can work as in association with other psychologists and all. You can definitely do that. But the question of will I do therapy or will I take someone along with me, like a mental clinical psychologist, etc., to work with me, it's something which you should decide. I had decided that I am going to do therapy, and I really, really enjoy doing therapy even now. Financially also, therapy is rewarding. it is like, even though you're taking 1 hour therapy session for a patient, so initially when you start off, the number of patients who come to you might be less. So if you do therapy, that is an added advantage, and you can charge slightly higher than what you take for consultations alone, so that you don't feel financially lost out on those. Working with other mental health professionals, again, there are a lot of things, whether you want to take, you want to employ them, give salary, or you just give your space to them and they charge their fee and you charge your fee. So these things are involved, and you should find somebody, like-minded to work, if at all you want to hire somebody. In the beginning, I would say that it is better to do therapy ourselves, and as and when we pick up practice, maybe we can get somebody along. But this is purely my own comment, and people are free to do what they want. What about recognition among peers? This also I have, I think, thought a lot before I wanted to venture out of NIMHANS, because leaving NIMHANS and going out was a very big thing for me. I was very passionate in being there. I had a lot of friends and all that. So I used to feel I'll be lost out and I won't have recognition among peers. I won't know anybody. Who will I discuss my cases with and all that? But now I'm realizing that actually in private practice, probably this is more than what it was in an institution, because now there's an effort from my side to know people. Like, when I go to some meeting or conference, I make an effort to talk to people. I make an effort to know people who are practicing in my area, seniors there. So I get to know more than what I used to be as a student, where I was not very much, bothered about all these things. Okay, how to set up? Will you set up your own clinic? Will you go to polyclinics, or will you go to nursing homes and hospitals? Sir has touched upon this, but I mean, just my experiences. Somewhere I had an added advantage because my husband already had a clinic, so I chose to just start there. Whereas people might not, everybody might not have such a thing where either your parents are doctors or you have a place to already start and all that. Then maybe starting off with polyclinics or even going to multiple hospitals in your area would be a good thing to financially sustain, and gradually, but ultimately sitting in one place seems to be people recognize you very well, as opposed to if you're a consultant in, say, 6 nursing homes in that area, people don't identify you with one place. Whereas if you're sitting in one clinic the whole day, it's easier for people to identify you, that yes, you are a doctor and you have this particular place and you sit there and you are available entire day there. Location of practice, say for example, if you want to look at Bangalore, there's a lot of difference in what South Bangalore is versus what North Bangalore is versus, so all these older areas versus what the newer areas are. The kind of migrant population you have in certain areas, they're not there in the kind of area that I live here. It's all old Bangalore, proper Kannadigas, who are there from very long years, middle class families. So it depends where you want to start, because it also depends on how much do you want to charge, how many people are already there in that area, etc. So choose the location of practice based on all these things. Do you want to see only outpatients or OP plus IP? Again, sir has spoken about this. What I do is it's mostly OP, but then I have a nursing home nearby where if at all the patient doesn't require so much of a monitoring, because all nursing homes don't have psychiatrically trained nursing staff and all. So we cannot admit extremely agitated people. However, those ones who are not very aggressive, but they require IP, I very rarely I do admit and I see them. But again, there is a lot of dicey things in this. One example I'll give you is there was a patient of catatonia who was admitted in a nursing home and I was asked to see. I saw that patient for 4 days, and my fee was 500 per day, that is 2,000, whereas the patient's bill was more than 1 lakh. So, I really got it was a very surprising thing to me, and somehow it was difficult for me to digest that this happened. So, these things I'm still learning, that how do you avoid such things. Or I mean, I really felt bad that the patient had to pay so much for this, for taking lorazepam and olanzapine, which she could have as well taken at home. Financial requirement to start. How do you sustain during the initial days? Depends on the family. What is your financial stability in the family? It differs if you're a male or a female, if you're married or not married. No, all these things are definitely there. So it's very individual decision. But I would say save up during your PG days a little. If you're earning good stipend and all, don't spend everything on movies and stuff. If you have this idea that you want to do private practice, save up some money, because the initial months you're going to go for a definitely loss. You will have to pay the rent, you will have to pay the receptionist minimum. I'm just telling these things. So at least to maintain all that, and even if you're not spending from your family, even then you'll have to sustain at least for few months with your saved money. So please do that. And like I said, you can start going to nearby nursing homes, give your visiting card, ask them to call you for any case. Can work as a senior resident or AP in a medical college and do private practice in the evening if that college allows you to do, so that there is some monthly salary. And as in when you build up patients, you can then progress to become a full-term private practitioner. Do you do online or only direct? Again, in the current days with COVID, with so many online platforms around, it is easier to do online than just direct. So I do both. I do a direct as well as online. However, there are certain tricky things in online where, I have had 2 patients in this 1 year where I just didn't know where they are from, and they refused to tell me anything about where they live, or they didn't want me to get in touch with any of the family members. They had suicidal thoughts, so I didn't want to treat. I told them that they have to visit a local psychiatrist. And certain online platforms, you are not allowed to prescribe any of the benzodiazepines. If there's a patient who necessitates that and you cannot give, then I was feeling that I'm not doing justice. So those are some of the tricky things in online. Should we use web-based platforms or not? I think Sharad has another session on this, because this is something which is very important. You cannot leave them. Whereas if you go, it's some sort of, I would say, exploitation. However, as you start, there is no other choice. You will have to go through them, because people have to know. Nowadays, everybody Googles, everybody goes on Practo. They just say nearest psychiatrist to me, top rated psychiatrist, and whoever has more reviews, it will just show up. So that's how it has become now. I think this will be discussed much in detail in further sessions, so I wouldn't go in detail. Yeah, practice general psychiatry or stick to specific. So when I wanted to start off, there were people who advised me that you do everything, like, marital therapy, family therapy, seeing child, geriatric, addiction, general psychiatry, everything, because they said that you won't have patients initially, you'll have to just sit in the clinic and you can't earn, so you do everything. Whereas there were a couple of people who told me that you stick what you want to do and don't take up everything. I started with doing everything, but by now I feel I cannot do everything, and I won't do justice if I do everything. And I'm planning to sort of cut them down to only areas which I really like, where I can do good justice to people. And I still want to keep individual therapy. I do want to do, because I really like, and I feel if you don't do therapy to patients, they don't feel satisfied, and they don't know how to get out of medications. Everybody will ask that, I don't want to take medications for a long time. What else can I do? So how do you tell them that you need to improve their coping skills, you need to handle stress better, etc.? So I feel therapy is very important, and I stuck to that. Work-life balance, like I was saying, it is a very, very important thing. to me, it was again something which I thought through a lot before I wanted to start, because I have 2 young children and I have nobody else at home. My husband is a very, very busy practitioner, surgeon. So I wanted to keep the evenings free, because they go to school, etc. in the morning times, whereas in the evening, I wanted to spend some time, having talked to patients so much about parenting, etc. I would feel that if I don't do that, then I'm going to fail in my own life. And maybe I will be a successful practitioner, but then I'm going to, fail personally. So I chose not to work in the evenings. I work for about 5 hours in a day. That's 3 hours in the morning and 2 hours in the afternoon. And I see maximum of 8 to 9 patients. As I was saying, I feel I cannot see more than that. I feel I'll not do justice if I see more than this in these hours that I do. Evenings is free for me, for my home, for my children, and for my own personal life. But yes, it again depends. If you are the only earning member, you're married, you want to start off, you cannot have this luxury of, maybe cutting down on time so much. But if it's possible, then it's always good to have some time for you, for research, for family, and stuff that you want to do. Yeah, I think I've spoken a lot, and I don't know, I'll be okay to take up questions later. Thank you.
Thank you so much, Dr. Lakshmi, for telling us about the experiences and as well as how you have taken these decisions. And it is a really wonderful share that you had. And all of this we remember is during the COVID period, during the height of the COVID period, which has really dented everybody's expectations with regard to how they would practice. But there's always been a big second charge for mental health itself that has really promoted this. And as you have mentioned, we will also discuss about web-based platforms. Right now we have our last panelist, who's a very dynamic and young psychiatrist there in Bangalore again, and she is going to tell us about leveraging social media to our advantage for improving our practice. And in all years, she's got a lot of things to tell us. And over to you, Dr. Sushma. Thank you so much for being with us here.
Thank you, sir. The pleasure is all mine. And after listening to the previous 3 panelists, I think I'm the lucky one here that I got to hear them. And I think since I'm the youngest and the freshest to private practice here, I think I learned a lot from this. So I'm really grateful to you as well as IAPT. So one thing is that in the last 9 to 10 months that I've started private practice, one thing I've really understood, like Anukant sir was mentioning, that visibility is everything. People need to know that you're there. And in the current era, social media is a very, very important and easy to use tool as well to sort of make yourself more visible to people out there. So coming to social media platforms as such, so the first things that people think of when we say social media is stuff like Instagram, Facebook, all of that. Apart from that, there is also a website called LinkedIn, which is sort of social media for professionals, which not a lot of us are aware about, unfortunately. So LinkedIn is again a very important and very useful sort of tool and platform where we can make ourselves visible to our own peers, to our colleagues, to our seniors, and a lot of other professionals who are not in mental health as well. There, we have an option called open to work as well. So people who are looking out for work, who are willing to join any or start any kind of work, be it like Lakshmi ma'am said, their own clinic or nursing homes, hospitals. So that is an option where you can make it very easily known that you're open to work. Apart from that, in LinkedIn as well, how do you actually network? Again, Anukant sir stressed on the importance of this. I'll just be adding about the virtual or the social media part of this. Stuff like actually talking to people online, connecting with them, commenting on other mental health professional posts, expressing your opinions, making sure you have a conversation there, following certain topics to keep yourself updated, and having certain forums where you can discuss about your topics of interest. All of these are also very important in building your profile, and through this also you get to know a lot of people. Honestly, I was not really a person who liked to put myself out there or really advertise myself. But one thing again in private practice that I've realized, visibility is really important, and you need to be willing to sort of let other people know in any ways and means possible that you're working, that you're here, you're available. And that does include both social media or virtual platforms, as well as physically going and meeting people. Both I felt are extremely important. So, of course, there are actual courses on LinkedIn itself, which teach you how to use LinkedIn. So for more details about how to use that very useful platform, please do make sure to go there and understand that. Apart from that, typical social media platforms, things like your Instagram, Facebook, WhatsApp, all of these are very useful in making yourself visible to other people. So there are a few things that I did. There are a few things I didn't do. So this is whatever I'm speaking is a combination of both my experience as well as a little brainstorming and getting ideas from other people as well. So with regards to WhatsApp, the other important thing before I come into each individual platform, it's important to understand two things. With each social media platform, there is a certain demographic that is involved. So you need to understand how to post where and what kind of post are you going to make, what target population is most likely to see these posts, and you need to tailor your message accordingly. So apart from that, it is also extremely important to not stick to one single platform. This is something that I realized over time, and I've tried to make necessary changes as per that. So with respect to WhatsApp, things like, sharing a status about where you're working and, what you're working as, which all days are you available, what are your timings, such things help. Posting in all kind of groups that you're part of, that, you're practicing in a certain place, the same things, where are you practicing and what days of the week are you practicing? What are your timings like? Make sure to share these specifics also in groups. So I did this among my NIMHANS groups, in my school groups, college groups, everywhere I could possibly think of. And the other thing I also did was asking people I was comfortable with to also share this particular message as their own statuses, or asking them to forward in their own groups. So this is that snowballing sort of effect that I tried to make use of. Apart from this, Instagram and Facebook, of course. So Facebook has more of a young as well as a middle-aged demographic. So you can not only post things like awareness about mental health. Apart from that, you can also do content of late like memes and jokes and a lot of other various ways to sort of educate people, again targeting the youth. And this makes mental health sort of more palatable and more relatable. That is also something that I've understood. So especially of late, we see a lot of youngsters coming to us. They do get to know us through Instagram, through Facebook, through posts there. And they do reach out to us in those manners. So it's also about how relatable you're making your messages and your posts. So which is why knowing your demographic also becomes important. So in Instagram and Facebook, it's mostly posts, and there are also certain options called stories, which are very short videos or small messages that you can post in these websites. Apart from that, another extremely important thing that I'd like to stress on is that repetition is very important. So people have very small attention span nowadays. So, you need to keep putting yourself out there that you're here, that you're working. And so one thing I did was putting up repeated statuses or reposting every once in a while that, I'm working at a certain place or I'm available between this time to this time. So you need to actually keep reminding people that you're there. So simply posting once or putting that message once there doesn't really help much. So you need to keep reminding people as well. Apart from that, also networking with your colleagues, like your psychologists or social workers who you used to work with in the past. So getting back in touch with them, informing them that you're available, that you're doing a private practice, that also helps them be able to refer patients to you. So that also I found social media platforms can really help a lot with getting to know who's there, where are they, and how can I reach out to them through these social media platforms and, get in touch with them. Apart from that, the other very important thing to remember with respect to social media is that it can be a double-edged sword. So in this era, we are extremely visible. So it's also important to be aware of what exactly you're posting, even when you're sharing your opinions when it comes to sensitive topics. Be careful about what you post, be careful about how you word your opinions. This also is really important in building your profile, because as easy as it is to use social media to build up your profile, build up your practice, it is also extremely easy to be brought down on social media very easily. So especially when it comes to sensitive issues, please be really careful about how you use social media for this. Apart from that, using it for awareness, using it to reach out to certain NGOs, and making yourself available for community work as well, if that is something you're interested in. Personally, I was very interested in that, so I could actually reach out to NGOs, and that again also sort of widened my visibility, and it made me available to those populations as well that those NGOs were serving. So all of these are certain ways that I can say that I've used social media, as well as tips on how to use social media as well. So I think that's it from my end. And if I can answer any questions, if anyone has, I think I'll be glad to do that.
Thank you so much, Sushma, for really comprehensively covering those things, and as well as sharing from your own experience and how you have gone through these things, and especially at the over these times, in these pandemic times, how you have built up your practice to where it is right now. Right now, I just would like to thank all the panelists for being there, for taking up very, very pertinent topics. A measure of how engaging it has been is that the participant numbers have not dropped. They have actually been increasing steadily as the meeting has progressed. So I'm going to now open the floor for questions, and I'm going to request Dr. Nikita, if you're there, please unmute yourself and ask your question. I think you have 2 questions posted here. It'll make it more interactive, and it'll also do remember this is an egalitarian space, and we'd really like for more of the knowledge transfer to happen without apprehensions either side. Dr. Nikita, please unmute and ask your question. Yeah.
Yes, sir. Good evening, sir. Again, this was a wonderful and unique presentation, and I think right in time for me as I just finished my post-graduation and just finished my MD, so still in the process of what to do next and where to go. So, one of my I have two questions actually. One was after the end of my post-graduation, now that we know what skills we have and what we don't, how do we go about developing the skills that we want to, which we have not been able to in our training period, you know, if we need those skills in further private practice. And secondly, like Lakshmi ma'am had mentioned, going for senior residency before venturing into private practice would be you know, she was in favor of that. So I wanted to know what should we look for before deciding where to do senior residency, and what should be our goals of learning, or, you know, say by the end of senior residency to be able to acquire this, or you know. So if some pointers regarding this, I would be very grateful. Once again, thank all the speakers for their wonderful tips and advice. Thank you.
Would you like me to answer? Hello?
Yeah.
Okay.
So please go ahead, sir.
Yeah. If you are looking for an SR post and you're wondering where or which particular topic of interest that you want to work in, my advice to you would be to go to do an SR post in an institution where they would allow you to work in the specialization you want to work in. Like suppose you want to work in geriatric psychiatry. So go to an institute which has geriatric psychiatry wards, and they'll allow you to spend a large amount of your time with geriatric psychiatrists. Or become an SR in a college which allows you to work primarily with child psychiatry, child guidance clinics, to family therapy and that kind of stuff. Basically, that is one. The second is, if you're looking at private practice and you are not decided in terms of marriage or other things, you do not have other commitments, look for other cities and look for consultants who are working in the field that you want to start in. Go there, speak to them, spend 6 months, 5-6 months, even if it is without stipend, sit with them, work with them, then come back to your town and start practice. There are a lot of students I get in my department. I'm in a small suburb just outside Bombay called Thana. And I get students from different cities. I don't have any specialities, but if they want to work with special cases, we do have a good OPD because we are a government hospital. We give them those kind of patients to handle. And under my supervision, we work on what could they do differently, what do they learn specifically, that kind of thing. It's an SR post. That is what helps you. Otherwise, you can actually, especially child psychiatry or psychotherapy, you can work in departments or with people who are practicing only that and learn from them. Okay.
Thank you, sir. Thank you.
Thank you, sir. Dr. Karthikeya Priya, you're there. You had a question. Could you please unmute yourself and ask?
Hello.
Yes, go ahead, Dr.
Can you hear
Karthikeya
me?
Priya.
Hi. Yeah. So does private practice mean that we have to sacrifice our family time? I heard Anukan sir mentioning that we have to do courses and during the weekends.
No.
Improvising our skills.
No. I didn't mention sacrificing your family time. I didn't say every weekend.
Okay.
I don't know if you have read, Indian Association of Private Psychiatry is actually running courses with Suicide First Aid, Safe Space. We are running a 2-weekend course spread over a month where they actually teach you about the act of suicide, and you get a certificate after being evaluated from UK of being a suicide first aid provider. It doesn't require you to sacrifice much time, few hours on a Saturday and a Sunday for 2 weekends, something like that. I'm not asking you to go for, these are all online.
No, for being a successful practitioner, do we have to,
Yeah.
be always available?
No, I do not take calls. I give every patient my personal mobile number with strict warnings that after 9 o'clock in the night and before 8 in the morning, they can call at any time. I will pick up, provided it is an actual emergency. And I've had patients who have called up in the middle of the night feeling suicidal or, feeling very agitated or whatever. I have more than 20,000 patients. I doubt I get maybe call once. I mean, my first call was after 12 years of my practice on my holiday when I was in Munnar. I got an emergency call from a patient from Coimbatore who was not my patient. I got a call, an emergency call to see a patient because somebody knew that I was staying in that resort at that time. And somebody in that resort became psychotic and they called me to go and see that patient. That is my first call. But no, you don't have to. The point which I mentioned, which Lakshmi ma'am picked up, was if you don't have IP patients, there is no question of you having emergency calls. The problem with indoor patients is that unless you have a reasonably good clinician who can manage the emergencies, you may have to rush in the night. There are people who actually have started just recently, students of mine, 6 of them together have started a hospital in Thane, 6 of them, and they take rotational nights on call between them, and they work with that. But yes, indoor patients means you should be ready for midnight calls and going out at night. But otherwise, you can put off your phone at 9 o'clock in the night and put it back on, professionally, you can put it off at 9 and take it on only at 8 o'clock in the morning.
Dr. Avinash, if you could also respond to this question, so that there's one, you had actually mentioned about taking time and how private practice was demanding a lot of resources, especially when you need to continue research and academic roles as well.
I totally agree with everything that Dr. Mittal has mentioned. The thing is that you very rarely, I mean, if you manage your patients well, which you will, most of you will, I think you're very rarely going to get night calls. I mean, invariably I work a little differently. I tell most of my patients to sort of WhatsApp me. And I tell them I will respond to you on WhatsApp. And if it's very urgent, then I'll definitely, speak to you. So I generally tell them, please keep messaging me even through the day. I'll respond as and when. If it's an emergency, then, please do call me and I'll pick up. That's not the problem. So this is how I function. Yes, I also cease to probably maybe answer too many messages post 9 p.m. But then if there are some patients who sometimes message in at around 11 p.m. that, we're not getting sleep, could we take an additional tablet of this or something? They message in on WhatsApp, then I reply them on WhatsApp. I've developed that practice over the years. So that is something which has come in. Apart from that, yes, on Sundays, I'm very strict that I would not entertain too many calls, and I'm very strict on weekends, maybe post today's seminar on the weekend, that I won't entertain too many calls. And I generally, on Sunday, look at my WhatsApp maybe once in 3 hours or 4 hours. So if there is any messages which are there, I'll definitely answer them. So those are the 10. Generally, you will get even messages for appointments on WhatsApp. So then you can look at your schedule and, give it to them. But you don't have to reply them like immediately. So you can plan, you can schedule your day wherein you look at all your WhatsApp probably once in 3 or 4 hours for 15, 20 minutes, answer the most relevant ones. The groups you can't be active on. If you're going to be very active on the groups, then probably you have a lot of free time. So that is not, going to work.
Thank you so much, sir, for that. Dr. Swarali has posted another question. Dr. Swarali, if you're there, please unmute and ask your question. I think your question is for Dr. Lakshmi. Yeah.
Yes, that's right. Hello?
Yeah, please go ahead, Dr. Swarali. We can hear you.
Yeah. Lakshmi ma'am, I had a couple of questions. One was if we want to take a decision of starting ECTs for a patient, so how would we approach that? The other was how did you fulfill your passion of teaching while being in private practice? And how do you the third question is how do you um, um, uh, what is your approach in maintaining boundaries with patients?
You're asking, sorry, I think by teaching, you're talking to me. Yeah.
Uh, so my question was to Lakshmi ma'am, because she had mentioned that
Sorry.
she had mentioned that she had a passion of teaching.
Right.
Yeah. Your first question about ECTs, I refer. That's all I do, because I don't think there's any other way, unless you have at least, a setup where you have a ECT machine or like coordinate with anesthetists, etc. So I just don't do anything. If I feel that the patient requires ECT, then I refer it to other institutions where that facility is available. That's all. Coming to your second question, I'm still struggling. Honestly, I don't think I'm doing justice to my passion of wanting to teach. But today, after hearing to Avinash sir, I was wondering if I can do something like that, like approach a medical college and ask for a visiting thing or something. But honestly, I haven't been able to do much there, though I've managed to continue some of the writing work, research, etc. with my earlier associations at NIMHANS and all. But when it comes to teaching, I'm still struggling and I need to see what I can do. Your third question was what?
About
Boundaries.
Maintaining boundaries. Yeah. I haven't had a problem there at all, honestly. I do give my number to all patients. Like sir was saying, I give my number to all patients because it's very important. It's so apprehensive about medications, etc. And they'll call you only in the beginning. Like, when you start off, if there is some intolerable side effect that they are experiencing, or maybe if they're suicidal and all that, only then they will reach out. Otherwise, I haven't had any problems with patients in terms of that, even though I give my personal number. Like sir was saying, I ask them to text me, and when I have time, I call them back and I speak to them. But none of them, I have not got any abusive messages, nothing at all. So not really much of a problem there.
Thank you, ma'am.
Dr. Mittal, would you like to respond again to the teaching aspects of it, how it could be built from here?
Right. I'm a DNB teacher and a DPM teacher. As I said, I have been examiner to 500 plus students. I currently have 4 PGs working under me, and I'm the only teacher. I have a lecturer. I have a AP working with me. I have 2 SRs and 4 JRs working under my department. I teach 3 days a week in the afternoons. I take clinics in the afternoons, and 3 days a week, my JRs take cases and they present to me in the OPD when we sit in the OPD and see patients. Alternate days, when I teach them in the afternoons, they present cases to my AP, my SRs, and my lecturer. I do a lot of mock seminars. We do a lot of paper presentations. All of my students present free papers, as Dr. Avinash said. Every conference, they have to present a case study or a basic study or something. And that is a parameter which goes towards me assessing them, not in terms of marks, but general assessments. And they are encouraged to do so. The more they do so, the more positive they feel. So we do that a lot. We take them for conferences. We have in Thana district, we have monthly seminars where our students make presentations. So they read up and they make presentations. So that's the way the teaching goes on. Right. And like Avinash, I read for 2 hours every day in the morning. So
thank you so much, sir. Dr. Pereira, you have posted a question. Would you like to please unmute and ask your question?
Yes, sir. Thank you for the wonderful presentation. My question was regarding the charges. Like, how do we decide what would be the charge of the consultation?
How much do you value your time? 30 years ago, when I started practice, there were 10 consultants around me who were the topmost consultants, 3 of them ex-Nimans, senior to me by 10 years. They were charging 200 rupees. I was UK returned, so I started charging 300 bucks. They increased it to 300, I increased it to 500. In 2 years' time, they made it 500, I made it 750. By the time they reached 750, I was way beyond them. So you decide what you charge. Frankly, even in a city like Bangalore, if I'm going to a hospital to see a patient, I wouldn't expect anything less than 1,500 rupees in my hand. Even in Thana, that is my rate. That is my expectation, and all doctors know it. And following me, all my juniors have started following me. It is how much you value yourself. You may get less patients initially, but today I see 8 patients. My students or my colleagues see 50 patients, but in the end, we take home the same amount of money. So you guess and decide who's better off. You can charge what you think is worth your time. If Dr. Lakshmi is seeing a patient for 45 minutes or 30 minutes and seeing a patient for 1 hour, she's charging differently, right? She's charging differently for a 30-minute consultation and charging differently. So you're charging for your time. If you go to Surat, they have a rate list put up, which was decided by the Surat Psychiatrists Association. For 20 minutes, so many hours, 20 minutes, so many rupees, 30 minutes, so much, 45 minutes, so much, and 1 hour, so much. They have this rate chart put up in the clinic outside the reception. So you have to decide, how much are you going to charge for a patient at 8 o'clock in the night on a rainy day? And how much are you going to charge a patient who's on your way or in the hospital where you already are sitting? Your consultation charges off clinic, in clinic should be different, right? Off clinic should be definitely 50% higher than what you would earn sitting in your clinic, because you're wasting that much time traveling to the off-site to see the patient. I go abroad, I go out of city. 70% of my patients are out of Bombay patients. And if I'm called outside Bombay to see patients, especially Delhi, Hyderabad, Bangalore, Chennai, Jodhpur, Jaipur, direct flights, I charge according to my charges separately from the plane bill and the hotel stay. These are what they have to pay for, and I charge. I've been to Kenya, I've been to Dubai, I've been to Singapore, I've been to Hong Kong to see patients, right? And it basically means that you put a value to your time, right? If a patient flies in from Hong Kong with a prior appointment to follow up with me, I'm not going to charge them 2,000 bucks, which is my normal fee. I'm going to charge them $200 because I'm going to spend 4 hours with them. They are flying down all the way from Hong Kong, spending a good $10,000, $5,000 to see me, right? Okay, I want to give them value for money, but I also want to get value for my time. So that's what I do. I'm sorry about being so frank with you guys, but proportionally, this was my rate even 10 years ago. So by inflation, you can calculate what it was that time.
Thank you, sir, for putting it so candidly and with so much frankness, as you mentioned. I think this is the reality contact and the decision-making help that all of us need in our early careers. One of our last questions is going to be from Dr. Shoaib Khan. Dr. Shoaib, can you please unmute and ask your question? And also, which panelist would you like to address the question? Dr. Shoaib, are you here? Well, Dr. Shoaib's question was about the laws pertaining to advertising, especially by doctors. And I think that comes in the context of being on social media and utilizing the social media to build up practice. I would request Sushma and any of the other panelists also to answer this particular aspect.
I think with respect to a law or at least regulations, I think there is one by Indian Medical Council, which sort of gives us directions about what giving out information is and what would sort of contribute to self-aggrandizement, if I'm not wrong. So I think I would also want to club another question I think asked by Rakesh sir. So regarding the law, I think that is the only one that I'm aware of. It's about your etiquette and ethics. So that is the only one that I'm aware of, which applies to the medical profession. There is also, I think, one question about the don'ts of advertising. So I think that is about not promising treatments or, sort of saying that this is what will happen for sure. I think that is one of the biggest don'ts. Apart from that, thinking of from a patient's perspective, also having a sort of polished presentation in your own advertisement that way, or when you're stating where you're available and all of that, making sure that the information is concise and you've given out all the details that is necessary. I think that is the most important thing. I'm sorry, I think I combined two things. I think
that's totally all right. Any of the other panelists, Dr. D'Souza, Dr. Mithil, Dr. Lakshmi, any thoughts on advertising and whether this qualifies as advertising?
Currently, all juniors that I know in many major cities are paying anything between 80,000 to 2 lakhs per annum to make sure that their profiles are in the top 10 on the most searched profile pages like LinkedIn or Practo or DocPlex or whatever. And they're actually handled by social media managers who make sure that their Instagram and Facebook and other media presence is prominently displayed. They write content for them. Probably, there are reviews posted by supposed patients for them, which bring them up on the charts. And these are things, but yes, there is a normal practice now. At least I have met about 7 juniors who are being managed by, who are paying social media managers to manage their social media presence and to make it more prominent. So, yeah.
Can I just add my bit? Yeah, though all of these which Sir just mentioned are there in practice, but my experience is that all of them are not like mandatory also. What I did was I just made a Facebook page on my clinic name, and I was doing of late. I've not done, but then I used to make videos on certain mental health topics and post them. Apart from that, I have not done anything else. So not necessary. I'm not paid anybody any social media. I mean, nothing, no digital advertisement or anything. I've not spent money anywhere on those things. So, it just depends on where you're working, what is the competition around, who are your patients, are they local people, are they more of a population who looks up online and comes to you and all that. So depends on all those things, but it's not like you have to imagine in your head, oh, I need so much money if I want to start. It's not needed at all.
True. Absolutely.
I think last smallest bit, sorry, Sharad sir, adding to that, I think,
go ahead.
I think even now, word of mouth is the biggest advertisement, despite social media, despite all other forms. I think that is something that personally for me has contributed a lot. So I definitely say that is also a very good form of advertising.
Right. So I think we have gone way overboard whatever time limits and whatever time durations we had asked the panelists for, and they have very graciously and consented and stayed on and answered all these questions. Thank you so much to all the panelists here. I would just request Dr. Mittal and Dr. D'Souza, if you could just share about the IAPP initiatives which are there, which you could like, as you mentioned about the suicide first aid course, and how can early career psychiatrists get to that, and what would you recommend they do? Just a small brief on that would be very useful. There are some questions with regard to that, so you could just generically
I
cover
think
that.
Dr. Mittal would be the right person to
Right.
answer.
Yeah, we have got 3 more slots opened up, 3 more workshops on suicide first aid coming up in October, November, December. If you wish, send a mail to Dr. Avinash. He will send you the links. You can register for them. It's not very expensive. It's $5,000 with a certificate from UK First Aid. It's a very good course. I did it 2 years ago and I was impressed with it, which is why I asked them to come and start training as psychiatrists. We are going to have courses on hypnotherapy. We have just today finalized working with ARDSI, if you know what that is, Alzheimer and Related Disease Society of India. They are going to run skill development courses for psychiatrists, doctors, and caregivers with us in the coming months, which are going to be online and sometimes offline. Even the suicide courses may be offline. We do have online webinars on various aspects of practice coming up. During our conferences, last year's conference in Bombay, I had about 50 workshops, which are hands-on workshops, starting with speed reading, hypnotherapy, infant psychiatry, all these things. Like, I don't know how many of you, probably everybody from Nemans knows that there is a Department of Infant Psychiatry in Christian Medical College. Do you know that? So, there are different things coming up. We try to help you and empower you. If you are members of IAPP, you tell us what kind of skill you want to develop. We will find specialists. We will liaise with them. They get bragging rights. We get their services and their expertise to share. We'll arrange workshops. We'll arrange skill building, skill transfer techniques, and you can learn. Just now I received a letter from Shubhrata. You know her, Shubhrata from, she's one of the sister psychiatrists from Shimoga. You know about her?
Yes.
Yeah, she just sent me on 17th. She's doing a conference on a webinar on lifestyle changes for promoting positive mental health, personal narrative by psychiatrists. And probably she does a lot of dance and drama therapy. So, you learn these kind of things and you can work with that. But I definitely would be running workshops with Avinash. Avinash is the expert on, brain stimulation techniques. So we would be running workshops on direct current brain stimulation, on EMS, all the kind of things that you would like, on EEG, how to read an EEG. We would be running workshops during our conferences, in between our conferences. So because we want to work with people who do not have institutions to back them. They are like the GP sitting in the clinic who need a CT scan fellow that they can call up to do a CT scan. They need a lab wala who will do the lithium levels ASAP. They need a person like Dr. Lakshmi said. She's got a withdrawal patient. She needs a patient admitted in intensive care. Where do you admit the patient? You need to have somebody who will admit that patient without you having to take on the burden of managing the patient, right? So we want you to learn all this because I have been in practice for 35 years. I'm on the verge of taking retirement. Anybody wants to take up my practice, come. You're welcome to stay in Bombay and take up my practice, right? So, we've learned all this the hard way. we've basically picked this up. Where did I get my foreign patients from? Exactly what the other two ladies said, word of mouth, right? In my time, there was no social media, right? I mean, I started my my Facebook account a year or 2 years ago. I was not on WhatsApp till about a couple of years ago, right? So it's all that you do. You do, but I have done loads of workshops in schools, loads of workshops in colleges, loads of workshops for Lions clubs, Rotary clubs, for all these kind of places. So people remember you. People remember that, oh, who that psychiatrist who talked about sleep hygiene workshop, right? I need to talk to him. That's how things start. So you need to build an image, you need to build your exposure, and that is what is necessary, right?
Right. Thank you so much, sir, for sharing about that. And I think we'll draw this webinar to a close. We'll draw this program to a close. I'd like to thank
Sharad, can I just add one thing?
Yes, please. Yeah, please go ahead.
There is this perception that you can't do ethical practice in private psychiatry. I have heard this as a resident. We always, people would say that in private psychiatry they'll do polypharmacy, they'll give everything. You can't do ethical practice and stuff like that, which is, I have realized now that it's completely wrong, and you can practice how you want. Like, if you really want to give just one antipsychotic, one benzo, it's completely fine. Nobody's going to stop you from doing that. So I think that shouldn't be there in your mind. One thing. Second thing is, I don't know if we didn't highlight so much, because Rakesh asked, please talk about positives in private psychiatry. I'm really, really happy. At the end of 1 year, I'm telling you that I'm more than happy than what I thought I would be when I started off. So it is quite satisfying, rewarding, and a nice experience. A lot of positives here too. So I didn't know if we spoke only about problems and didn't make it look positive. Yeah.
Can I add
yes,
one thing?
Please go ahead. Yes, sir.
I own an S class and an E class. Thank you very much.
Thank you, sir. That's a positive to look forward to. Right. Thank you so much to all the panelists. Our patron also has stayed on till this moment, and this has been a very educative session. A lot of people have stayed on. A lot of doubts have been answered, clarified. There are a lot of people who made it possible. The entire technical team, Doctors Prabhu, Vishu, and Thomas, who've been handling all the nitty-gritty of things, as well as looking at the platform and the Zoom and arranging everything, has been fantastic from them. There's been a fantastic organizing effort. We'd really like to thank all the members present here, all the audience who is present here. Do stay on, in the coming days and weeks. We will be sharing more details about some more aspects of private psychiatry, especially pertinent to early career periods, as well as just after you finish training. We'd really love to know your feedback about this. So you have the email IDs mentioned in the flyers through which you've joined in here. You can always send us or shoot us an email about the particular topic, as Dr. Mithil was also mentioning. It's there. The expertise is there. There are seniors there. There's a lot of scope for knowledge transfer. There's also now increased ways of disseminating this knowledge. I would also like to request people in the training period and the early career period to join the IAPT. It's a not-for-profit. It's a subscription-based organization which looks at overcoming all these inequities, as Dr. Mithil mentioned, that we don't receive all of those aspects of training, but we can definitely bridge them. We can definitely overcome those inequities by collaborating and connecting like this, and discussing and doing these things. So we need your help. We need the audience, and we need you, for whom we are doing these events, to let us know about how this has been and what you would like to be addressed in the future sessions. I will draw this program to a close now. We have overshot the time that we had anticipated by more than 30 minutes. I'd like to really thank all the panelists from the bottom of my heart, and thank you so much for making yourself available, for sharing so much of your wisdom and knowledge here on this platform. Thank you so much. There's a lot of responses which are there in the chat. Thank you so much, Dr. Mithil. Thank you so much, Dr. Avinash and Dr. Lakshmi and Dr. Sushma. This has been fantastic. You will see some of the links to connect with the IAPT in the chat. Would really request you to do that. A simple way is to just log into our website, and we have more details for you over there. That's www.iapt.in. And let's do greater things. Let's do better things. Thank you so much thank you so much for being here.